Hello, and thank you for joining our e-seminar featuring our guest speaker, Dr. Art Mallinson. The e-seminar is titled Evaluating Malingering and Work-Related Vestibular Injury. My name is Teresa Boone, and I'm the Director of Global Education at NATIS, and I'm delighted to host today's e-seminar. This presentation is presented as a how-to session aimed at outlining the steps to carry out a thorough assessment of the medical legal patient in a comprehensive and unbiased manner. I'm honored to introduce today's guest speaker. Art Mallinson is a neurophysiologist with a bachelor's in biological science and his master's in neurophysiology, both from Simon Fraser University in Burnaby, Canada. He earned his PhD in health medicine and life sciences from Maastricht University in the Netherlands. For the last 33 years, Art has worked in the neuro-otology unit at Vancouver General Hospital and is a clinical instructor in the Division of Otolaryngology, Faculty of Medicine at the University of British Columbia, with a cross-appointment in the School of Audiology and Speech Sciences. Dr. Mallinson performs clinical vestibular assessments and interprets assessments from other centers across Western Canada and serves as a consultant in interpreting difficult or unusual vestibular assessment results. He's been performing and personally interpreting computerized dynamic posturography assessments for 25 years, including thousands of medical legal assessments. Dr. Mallinson and his research colleague, Dr. Neil Longridge, have co-authored a booklet about medical legal evaluation and balance. Dr. Mallinson, we're very excited to hear your talk today. The presentation is now yours.
Oh, thank you very much for that nice introduction, Teresa. Very nice to be here, to be with everybody via the internet. So I thought we'd go through sort of how we do it seminar, as Teresa mentioned. First of all, I can say that using Equitest as a tool for assessing the medical legal patient is extremely helpful. I'm sure I don't have to tell you that these patients are often very complicated and have symptom sets that are difficult to sort out. Today, I'm going to share some of the concerns we have had over the years with respect to assessing these patients and go through the protocol that we have developed in our lab for doing so. When we're finished, I'd certainly be interested in anybody's ideas via email and anybody's thoughts as well. Basic SOT assessment, I don't think there's any need for us to go through this. But the point should be made that while Equitest is a very good quantitative tool and helps us measure the signs of a balance system deficit, it is also a qualitative assessment and assists in measuring the symptoms of a balance system deficit. In addition to a patient being off balance, quite often they just feel unwell. That's very, very difficult to get a handle on in quite a number of patients. And posturography is very helpful in this way. We don't have time to discuss this symptom set in detail today, but I'm sure many of you are familiar with the kinds of complaints that are voiced by patients. The interested reader is referred to any of the space literature about space motion sickness, for example. Suffice it to say that simulating a patient's symptoms with an SOT is a very helpful aspect of the assessment, and it has been documented in the literature that a symptom set that is simulated by posturography, SOT, strongly suggests a vestibular deficit. And we've had patients, I'm sure many of you have as well, oh, this is the same feeling I've been trying to tell the doctor. It's very helpful to the patient and very helpful to the diagnostician as well. It's very important to remember that the symptoms of vestibular disease can be as debilitating as the signs. If you're extremely off balance all the time, your job as a house roofer is going to be in jeopardy. In addition, if you are extremely nauseated and sweaty feeling all the time, it can also be a problem with respect to work. Some patients, and even some of our medical legal patients, emphasize that they are not noticeably off balance. They just feel unwell all the time. The point I'm trying to make is that even a normal posturography assessment can still be exceedingly helpful to the diagnostician. Here's a summary of what I'd like to talk about today. The three most important things in real estate, which you learn on the first day of real estate school, are location, location, location. If you're assessing any vestibular patient, and especially a medical legal patient, the most important things are history, history, history. Regardless of any time constraints you may have, you must sit down and listen to the patient's story. A detailed, accurate history must be taken in a non-leading manner. In other words, not suggestive of any answers that you might want to hear. We're going to mention that a little bit later as well. The assessment must be fair, and a decision must be made using all aspects of the assessment. So I'm also going to take you through how our interest in the subject has developed over the years to develop this way or this technique we have of assessing the medical legal patient in a fair manner. The aspects of natural justice. The aspects of natural justice must be adhered to regardless of time constraints. Oh, I don't have time to do this. I'm too busy. My waiting room is full. You cannot do that. A resident was with me today, so I had to hurry my history. You cannot do that. The tenets of natural justice state that a person should be given a hearing. We've already emphasized that. Decision makers should be unbiased, and they must come into the assessment with no preconceived ideas or opinions. Fourthly, the decision has to be arrived at solely on the merits of the case, what you have listened to, what you have assessed the patient for, and the findings that you have made. The principles of natural justice are paramount in assessing these patients. So legally, if you talk to lawyers, they talk about natural justice. To my research colleague, Neil Longridge, and I, we just feel that this represents common sense. You just listen to what the patient says, using your background, anatomical and physiological knowledge and experience, you try and come up with a reasonable suggestion of what might be going on. So a lot has been talked about with regard to medical legal patients versus non-medical legal patients. What is the difference? We wondered, what is the difference between a medical legal patient and a non-medical legal patient? In a blinded retrospective review, Davies and Luxon suggested these two groups were similar. They looked through a bunch of patients and they were blinded to whether they were medical legal or not. They found that there were close similarities in the presentation, in other words, in the kinds of symptoms they had, and also in the nature of the complaints, and also the incidence of abnormalities in both groups. They came to the conclusion that strong evidence for an organic basis to recurring dizziness after head injury, whether or not a claim for compensation is pending. So just because you have an ulterior motive or are seeing a lawyer doesn't mean that the complaint is less legitimate. They felt very, very strongly about this, and as I said, it was put in the literature. We also came across some different opinions in the literature. Giannoli in 2000 wrote basically that if you have a lawyer and you come to our clinic, we should probably be suspicious of you the minute you walk in the door. So we have two different schools of thought and wondered how we could resolve the two. Which attitude should we have when we assess our patients? We thought, well, we have to develop some strategy to determine legitimate CDP performance. You come on and you get assessed with posturography, and there's an abnormality. Is it a legitimate abnormality, or is it something else going on? We were utilizing CDP at the time that Giannoli published his paper. We were seeing medical legal patients, and we thought, well, we better develop some kind of strategy so that we could follow, a strategy that we could follow so that we could document, quantify, and legitimize our patients' complaints. Yui Monin in 1995 also took this into account, and he was one of the other groups of investigators who tried to develop ways of catching people who were perhaps embellishing their symptoms. He took a group of the patients with legitimate vestibular disease, a group of normals, and a third group of normals who were told to pretend to act dizzy. And they found that the assessors, experienced assessors on posturography, were able to catch the imposters, the people who had been told to fake a disorder. Goebel set out 7 criteria for aphysiologic CDP response. He felt, well, there should be some kind of criterion, some kind of quantifiable method by which we can score the patient to see if their results were legitimate. And this was one of the first efforts to develop a strategy to assess the patient in a reasonable manner and give them a so-called score of how well they had done. He refined his criteria a little bit. He found that 3 of his criteria were in fact very helpful in a fair assessment of the physiologic patient. Important to remember is that there was a score of the patient's performance, but there was also a subjective way to look at the raw data. As Goebel said, you look at the consistency of the raw data. So this isn't just a number that's assigned, but it's also a way of having a look at the data. So that made the whole process quantitative. So now when the patient came in the door, you could do posturography, get out your calculator, and categorize all patients. We saw this in the literature. We thought about this whole scoring system, and we felt that some improvements were necessary because all patients were now assigned a number, and the number you got was the group you were in. I'm not going to require people to remember this set of equations. By the way, I do not ask residents to memorize these equations. However, I'm just throwing them up there. He reported his accuracy to be quite high. Krempel and Dobie tried to compare the 3 methods, to try and catch purposeful malingerers and legitimate patients. What they did, they had subjects come on and give their best effort. Do your best. And in the second trial, they had them fake a disability. Okay, now fake that there's something wrong. The third trial, they actually had them do posturography while calorics were being done, so it made them into vestibular patients because it created a vestibular weakness on one side. They wanted to see what the differences were in the posturography scores of these 3 different behavior groups, if you'd like, to see if they could be caught. They wanted to see if one method was more accurate in picking up behavior of these patients because they compared the Savette equations, which we've already been through, the Goebel criteria, which were developed, and their clinical scoring, just the way they did it. Giannoli felt that the Goebel criteria were still the best set of tools to use. They looked at the 8 criteria. They looked at lateral sway during SOT, and they used the Goebel formula that was developed. And basically, the Goebel formula said take the scores of conditions 1 and 2, and if they're worse than conditions 5 and 6, the raw data, then there's a very good chance they're malingering, and you can catch 95% of them. They called this the hallmark of aphysiological performance. In other words, this was a way you could figure out if a patient was telling the truth or not. However, notice that they also emphasized the importance of clinical judgment. In other words, what did you think about the patient? Morgan used pseudo-malingerers. And what he did, took a group of people and instructed them about how to fake on posturography. When it starts to wobble around a little bit more. On the conditions where the platform is moving a lot, then wobble around a little bit more. He gave them lectures or lessons on how to fake. He found out that the Civet equation, which we've been through before, and clinical scoring was equally effective. But additional information about how to fake, in other words, a really experienced person who could really put on a good show, could still be caught. The practiced faking patient could still be caught. Well, Dr. Longridge and myself, Neil and I, read all this literature and wondered what the differences were between these two groups of patients we saw. We saw patients who were medical legals. We saw patients who were not medical legals. Were we assessing them fairly? Could we tell the difference between the two groups? We took these two groups and separated them into patients who had been hurt at work with a resulting vestibular injury and ones who had no ulterior motives whatsoever. And we set up an experiment. 170 patients. This is the criteria that they went through. They had dizziness questionnaire and basic neurological history, full ENG with caloric testing, and full sensory and motor CDP. This is before the advent of VEMPs, so I'm not going to get into VEMPs just now. But we wondered, could we catch patients who were not genuine? Could the Civet formula do the work for us in a fair and accurate manner? Maybe we could just get our calculator out and bang in the numbers and be done and make a lot less time and a lot less work for us. And most importantly, what were the differences between the two groups, the aphysiological group and the not aphysiological group? Well, what did we find? Look at these two groups. Calorics are abnormal in over a quarter of our non-trauma group. These are regular vestibular referrals referred by ENT doctors, sometimes neurologists, with vestibular complaints, traditional vestibular complaints, often things like spinning, and that one would expect calorics to be normal in a high group of patients. In our trauma group, note the high rate of CDP abnormalities. This is highly significant statistically, and it shows that right off the bat, before we address anything further, there is a very high rate of posturography abnormalities in our trauma group, our group of patients who had hurt themselves at work. Were they aphysiologic or not? Well, using the criteria we used, we judged 3 of the 109 patients were subjectively judged. We thought that they just weren't telling the truth. They were flagrantly aphysiologic. In our non-trauma group, as might be expected, none of our 61 patients displayed any aphysiologic behavior at all. Okay, we gave each patient treatment with the Civet analysis, and the Civet analysis was a little more strict. 1 in 6 of our non-trauma patients were called aphysiologic. 30% of them were called vestibular, and more than half of them were classified as normal. In other words, and as I mentioned before, these are patients who had waited 6 months to come in to see us. They would have canceled their appointments if their symptoms had settled down to a sort of a tolerable level. So we were concerned about this. Our non-trauma group screened out anybody with ulterior motives. For instance, if you had any long-term disability claim or anything like that, you were screened out. And as I mentioned, they must have been legitimate. They had waited 6 months and often driven hundreds of kilometers to come to our clinic. Why did Civet classify 1 in 6 of our patients of our non-trauma patients as aphysiologic? We realized that some of the patients had been classified normal, remember half of them were normal by Civet, because of normal or near normal CDP. As I mentioned before, some patients have normal CDP but are still extremely symptomatic. The Civet formula successfully caught the 3 malingerers that we had judged to be aphysiologic, but also called 33 other patients aphysiologic. In addition, 10 of our 61 non-trauma patients were called fraudulent. So we were wondering what was going on. A point to be made, of our 10 non-trauma patients who were called fraudulent, 3 of them had caloric reductions, which we accept as genuine vestibular pathology. So, as I mentioned, Civet had made the whole process quantitative. We got our calculators out, banged in the numbers for everybody. Here are the Civet equations again, in case you haven't memorized them just yet. Note that they give different weights to different SOT scores. We examined this a little bit more closely because we were concerned that many of our atypical patients with atypical posturography abnormalities, for instance, a typical posturography abnormality would be condition 5 and 6 down, or maybe condition 4, 5, 6 down. But some of the atypical posturography abnormalities were classified as malingering. Notice the classic CDP abnormalities, as I mentioned before, 3, 5, 6 down, 4, 5, 6 down, they're classified as legitimate. The atypical patterns, 1 to 6 down or 3 to 6 down, these are patients, or these are representative of valid vestibular pathology. It's in the literature. They're so-called atypical. They were classified by Civet as aphysiologic. In addition, notice that the Civet formula totally ignores the scores on condition 5. I'm not going to go back to the Civet formulas in case anybody's getting a headache already, but condition 5 scores are totally not looked at all. Even though the 5 down pattern, that is a paper that's been published, it was also presented at the Bharani Society this past year, it is a legitimate deficit pattern, again, totally ignored by Civet. So that's where we were at. We had some concerns. What are we going to do about them? If you've got some concerns, you've got to develop a theory or develop some kind of plan of action to do something about it. We recognize that a comprehensive but fair set of criteria must be developed, which combined subjective impressions, which we thought were very important, and other authors had also suggested were important, with objective evaluation, because you have to measure a patient's performance. You have to measure how poorly or how well they're doing. It's important to remember again, these criteria must be drawn from previous experience reported in the literature and from concerns raised by others, as I've suggested in the literature that we'd read. We developed a set of 9 criteria for assessing these patients. And as we go, we're going to go through the criteria one by one, but as I say, it is we feel, a fair way of measuring a patient's performance and also evaluating their qualitative problems. I'm going to show you how our study patients that I've talked about, the 171 patients, scored using our 9 criteria. We developed the criteria, went back and scored all the patients using our 9 criteria. Then we will go step by step through how we developed each criterion, why we developed them, why we thought they were important, how it is backed up in the literature, and how we use it in everyday practice. I'll go through these quickly right now. As I said, there's more detail to come. 9 criteria: better performance on SOT on 1 and 2 when unaware. I'll talk about that in a minute. Number 2, high intertrial variability on all SOT trials. Number 3, SOT 5 and 6 relatively better than 1 and 2. Number 4, circular sway. Number 5, repetitive suspicious sway patterns. Number 6 and 7 sort of go together: exaggerated motor control test responses and inconsistent motor control test responses. Number 8, 1 and 2 markedly below normal. That's slightly different than criterion 3. And number 9 is our clinical judgment, and I'm going to talk about that in quite a bit of detail in a bit. So we have 9 criteria here, a way of scoring a patient. We regard a score of 3 or less as physiologic. Now, it doesn't have to be that everybody gets 0. Some patients may have developed a quirky or maladaptive compensation strategy, just some weird way of doing it. It's the way they've developed it. It is not a good, efficient method of keeping balance, but it's what they've developed anyway. Existence of 1 or 2 of these quirks is not suggestive of malingering. And there is a precedent for this. I don't know if there's any physiatrists listening, but Waddell's signs, there are 5 signs for sort of embellishment of lower back pain in patients. And Waddell's signs, if you have less than 3 of the signs positive, then you're considered to be legitimate. So that's what we do. We regard a score of 3 or less as physiologic. We went back to our group. Our clinically suspicious malingerers, remember there were 3 of them who were flagrant. 2 of them scored 6 out of 9. 1 of them scored 5 out of 9. Obviously, we were able to catch them, quotes unquote. All the other WCB patients, the other 106 of them, 3 of them scored 3 out of 9, sort of borderline. 9 of them scored 2 out of 9, and all the other patients scored 0 or 1 out of 9. So, in brief, most of these patients were more or less legitimate. CDP abnormalities. What is a legitimate CDP abnormality? Well, this is an aside, but there's 1 or 2 things I wanted to mention. This has been published. We have identified an abnormality called the across-the-board abnormality. It's been published, and it is a condition, it is an abnormality where all 6 SOT conditions are slightly down. This is a legitimate condition, and we looked at our group of patients, and we found that 10% of our normal group had this, and 30% of our WCB group had this wrong with them, had their sort of 1 to 6 down abnormality group. So our only concern here, we recognize this is legitimate. It is in the literature that it is legitimate. Our only concern is that if you've got that pattern of abnormality, you're going to get classified as aphysiological by the Civet formula. That's just the way it is. What makes us think that these across-the-board abnormalities, in other words, conditions 1 to 6 are all slightly abnormal? How did we know? What made us think that this was legitimate? Well, first of all, it's been shown by Owen Black and a number of other investigators to do with NASA in returning astronauts that they do very, very poorly on posturography when they land. And they do show abnormalities across the board. All conditions are abnormal. And it's been shown to be because of otolithic disruption and disturbance when they're in space. So the bottom line is these astronauts returning from space with those abnormalities would be called as aphysiologic by Civet. Of our patients with this CDP abnormality, 6 of them in our non-trauma group, 4 of them had caloric reductions. So that was a concern we had with the Civet formula. We thought that something else needed to be added to it. So here's the 9 criteria again. Let's go through them one by one and see how we administer each criteria, how we administer the tests, and how we score each one. The point can be made that maybe some of the criteria are more important than others. Maybe some of them should be weighted, and one criteria should be called 3, and like 3, and one criteria should just be called 1, because one is more meaningful than the other, so to speak. But we didn't want to get into this. We just wanted to get some way of using a positive, negative, or yes, no scoring condition. And that's what we do. We use a yes, no scoring. The first thing we do, we repeat conditions 1 and 2 3 times. Some people say, well, you do condition 1. Everybody can do condition 1. let's just do condition 1 once. Let's just do condition 2 once. We do conditions 1 and 2 3 times. The reason we do that is because we want to see if it's consistent. Secondly, we have developed a way of catching people when they are unaware. Now, this is talked about by Allam and Shepard. If a patient is given a chance to embellish or put on a show and they choose not to, then that is in their favor. They've been given a chance on a silver spoon and they don't do it. That makes it possibly more legitimate. If you don't take this golden opportunity, then it's possibly more credible. So when we perform conditions 1 and 2, well, for want of a better term, we lie to the patient the first time. The first trial of condition 1, the patient is told, I want you to stand very still. The computer has to be zeroed. The platform has to flatten out. Then on conditions 2 and 3, okay, I'm going to measure your balance starting right now. So if the patient performance is exactly the same when they don't know they're being monitored as when they do know they're being monitored, then that is helpful in legitimizing or making their complaint more genuine. They didn't take the chance you gave them. So that's criterion 1. Criterion 2, high intertrial variability. Differences between trials will be greater in aphysiologic patients because they can't remember how well they did the last time. Legitimate patients have legitimate, reproducible deficits. How do we do this? Well, some clinicians, when they do posturography, they just do it just the way, well, condition 1, condition 2, condition 3, 3 of them, condition 4, 3 of them, condition 5, 3 of them, condition 6, 3 of them. And you tell the patient what they're going to get. We don't do that. We do our technique of condition 1 3 times, and then condition 2 3 times, like I was saying. Then afterwards, I basically pick what the patient gets next. The patient is told, when you're standing there, what you're looking at might wobble around a little bit with you. And what you're standing on might wobble around a little bit with you, or both. I just leave it. I leave it there. I say, you stand there and do nothing. This is not a ride. You stand there and do nothing. And then I go and pick what the patient is going to get next. Condition 3, 6, 4, 3, 6, 5, until I've done 3 trials of each one. So the patient has no idea what they're going to get next, and the performance on, say, condition 4 should be about the same on all 3 trials. Performance better on conditions 5 and 6. Now, remember we talked about Goebel's criteria. It was the hallmark of aphysiologic performance. A legitimate patient won't do as well on conditions 5 and 6 because it's taxing the vestibular system and not allowing them to use other information. So that's very, very strict. And anybody with any experience in administering SOTs can tell if the score on conditions 5 and 6 is legitimately worse than on conditions 1, 2, 3, and 4. I don't have to put an example of this up there because everybody has seen this before. You sort of know what it looks like and know what it should look like. Conditions 5 and 6, even in normal people, should be slightly poorer than conditions 4 because they are harder. They tax the balance system. So we note where the abnormalities are and we see if the drop-off in performance by a patient makes physiological sense. Criterion 4, circular sway without falls. It is unnatural for a patient to sway in a roundabout manner to keep their balance. That is not something that a normally functioning vestibular system would do to sort of describe circular sway. When you get home or when you finish listening to this, try it yourself. Rock back on your left heel, then over to your right heel, then over to your right toe, then over to your left toe, and go round and round and round and make a little circle like that. That is extremely hard to do. If you can do it, then your balance function is fairly good. However, if you want to demonstrate that your balance is really, really bad, you might do that so that I, as a clinician, would sit there and watch you go round and round and round. If you have a look at the raw data, it becomes quite evident that that is a fairly obvious sign on the data. So we just have a look at that and see what it looks like. This isn't a fantastic example, but it's not an excellent example. But if you'd like to try it on your own, as I said, give it a try, and you can see that if there is something like that on the COG plots, then you can pick up on it quickly to see if the patient was making a sort of an overlying attempt to make their balance look very, very bad. It takes good balance to be able to generate that without falling out of your cone of support. Criterion 5, repetitive sway patterns. The characteristic signs of a simulated performance in those who are told to do so are repetitive patterns of sway, which change very slightly. This is another feature which can be visualized. Even if you aren't experienced at doing SOT, I can show it to you and you can say, oh yes, that looks different than in a normal patient. And that's what we do. We examine the raw data for repetitive patterns of sway. They become quite evident and they help you sort out a basic SOT score. Here's a good example. I'll show you a good SOT score, a good sensory organization test. Look at this patient. This patient has terrible performance on condition 3, and they can't cope with conditions 5 and 6 at all. Let's evaluate this patient. They've got a legitimate vestibular deficit, right? The strategy on condition 3 is very poor. Okay, let's look at the whole data set. In actual fact, this patient is not a patient. This was me purposely generating the pattern. I had to show the residents what a 3, 5, 6 down pattern looked like. So I had my staff give me an equitest so I could fake a 3, 5, 6 down pattern. I showed them the bars and said, this is what it looks like. It was very helpful. The only way I could generate the poor performance, I'm experienced, I've done this lots, I've watched it lots. The only way I could do that was to generate this rhythmic aphysiologic sway. With my presumed experience, I should be able to fake anybody if I wanted, but that experience isn't going to help me at all. I will still get caught. Look at the beautiful rhythmic sway. It's not a reflexive attempt to keep balance. It is, shall we say, a cortical or a thinking brain overlay in order to show you how much I'm wobbling back and forth. Oh, look at me. Look at how bad my balance is. Let's look at the data a little bit more closely. Here's the raw data. I've just blown it up a little bit. It shows the use of both sway forces, so-called ankle strategy, and shear forces, so-called hip strategy, to try and, quotes, maintain balance. Again, this is not a strategy invoked by the vestibular system to try and maintain balance. This is a strategy where I lean forward to the edge of my cone of support and then lean backwards to the edge of my cone of support the other way, oscillating back and forth about 12 degrees, which, as you are aware, is the maximum amount of oscillation that can be coped with. So right off the bat, again, even if you're inexperienced, I can show you this and see what a rhythmic, repetitive pattern this has shown. Criteria 6 and 7, inappropriate motor control responses. We do motor control testing all the time. It's sometimes helpful in delineating vestibular spinal reflex abnormalities, but many, many times these patients have been sent by neurologists with no evidence of any pathology. So that's not the main reason or the principal reason we do the motor control testing. We do it because we like to look at the raw data. The motor control test measures the vestibular spinal reflexes using repeated platform perturbations. As we're aware, it just jiggles you again and again and again. Any attempts at embellishment cannot be reproduced, especially when we randomize the task presentation. So as you're aware, there's small forward, medium forward, and large forward, and small backward, medium backward, and large backward. So maybe if you were really good, you could figure out, okay, I should wobble a little bit more now because it's going to be bigger. I randomized forward, backward, small, large, and a legitimate response, because all I'm doing is picking up vestibulospinal reflexes, will be completely repeatable. Another thing we can look at is, for example, a patient has an extreme 4, 5, 6 down abnormality, suggesting that they are totally reliable on their support surface. Then they should also be extremely unstable on motor control testing, which irritates the support surfaces or moves the support surfaces. If you can cope with that during motor control testing, but you cannot stand on condition 4 without falling, those two things just don't add up. If your motors are perfect, but you have 9 out of 9 falls on conditions 4, 5, and 6, it just doesn't add up. And in fact, Neil and I have discussed making this a 10th criterion. Maybe we should make it a score of 10 instead of 9. So that's what we do. We examine the raw MCT data for appropriate motor control sway. Responses should be reproducible and also appropriately larger. If I jiggle the platform more, your reflex response should be a little bit higher in amplitude. Here's a couple of examples. This is physiologic motor control test sway. It measures the sway and the shear and the center of force of all these patients. Hit sway and shear and center of force, sway and shear and center of force for small, medium, large backward, and small, medium, and large forward translations. Every trial is done 3 times. Even if you've never done this before or have never performed it before, you can see that the sway and the shear and the center of force movements are exactly the same each time. The patient's responses overlie each other virtually perfectly. So this patient is not embellishing or making anything up. They must represent reflexive responses. Compare it with an aphysiologic mess. Total intertrial inconsistency all over the place. And look, there's small, here's medium, here's large, but they're about the same amplitude from sway and shear force. And also we've done it again and again. There's no overlying. It's nowhere near as pretty as what I've just showed you. It's not appropriately scaled and it's not consistent. So that is highly suspicious. If it's not obvious enough, let's lay the two beside each other. On the right, we see what a pretty normal one should look like. Bang, 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 except with exactly the same each time, as opposed to one on the left. Very, very large late responses, discordant responses, and very large responses to even small platform perturbations. As anybody who's experienced with posterography is aware, the small platform perturbation isn't really very much. It's not much of a perturbation. I don't know exactly what it is in degrees, but it's not very much whatsoever. So this is another way of helping to legitimize the patient's complaints. Criteria 8. SOT 1 and 2 are markedly below normal. Well, conditions 1 and 2 are equivalent to office Romberg testing. Even easier, because I don't make you put your feet together Romberg test or a sharpened Romberg, you have to put your feet together. This one, you just have to stand there. Although minimal legitimate deficits are sometimes seen, a patient who has walked into the office unaided, down our hall and around our corner to the assessment suite, should be able to perform reasonably well on condition 1 and 2. Even a patient with no vestibular function whatsoever, if you say, please stand there still with your eyes closed, they can do it. So we always perform, as I stressed before, we always perform conditions 1 and 2 3 times each. Now this, again, isn't a fantastic example, but here's an example of the criteria. Raw scores on condition 1 and 2. Look at this patient's 5 and 6. They do pretty well on conditions 5 and 6. And the score on conditions 1 and 2 is about the same. Again, this is immediately evident. It leaps off the page at you and says, oh my goodness, there's something going on. The patient cannot perform on the easy trials, but can perform quite well on the more difficult trials. Condition 9, subjective evaluation of the patient. We just call it a gut feeling. And the gut feeling, while not the whole story, of course, is an extremely important aspect of how to assess the patient. A subjective evaluation of a patient has been shown by investigators to be as accurate as an objective assessment. So what we do, we independently arrived, was 2 of us, an ENT clinician and myself, both assess the patient on the same day so that the patient is seen by 2 separate people using the tenets of natural justice and also our criteria, and they are uninfluenced by each other. We do not share with each other our opinions or our evaluations until the evaluation is complete. This is our way of trying to get a subjective evaluation of a patient. It is extremely important to do this. For example, I never have a resident go and get the patient for me. I never have a medical student go and get the patient for me. Our trip from our waiting room to our assessment lab involves walking down a number of hallways, turning a number of corners, which are quite sharp, going up a slight incline through our audiological suite because all the wires are underneath, going down a small incline as well, and walking in a very, very pretty building. We have a very nice building so that patients look around a lot. So a patient who is walking up and down an incline, looking around at an unfamiliar situation, and looking at different people walking past and talking to me, because if I chit-chat with the patient and tell them that we're going to do this or do that and strike up a conversation, they will look at me. If somebody is talking to you, you look at them because it is rude not to. So this is my way of evaluating the patient to a certain extent to see if they move in a natural, fluid manner in a natural environment. And then they turn, they come into the assessment suite, they lift up one foot to take their shoe off, they pivot turn quickly and place their purse on the floor, and then they take their coat off and pivot the other way and wash their hands or their face before they start the assessment. That is a way of stressing the vestibular system, and a patient like that who then cannot even tolerate condition 1 or has 12 out of 12 falls on conditions 3, 4, 5, and 6, it just doesn't add up. In other words, if I stress their vestibular system when they're not aware of being assessed, then they perform well. And if I stress them in a formal assessment, then they do not perform well. This is part of the assessment process. It is also very important, as I said before, to evaluate the patient from the symptom point of view. we often do this. I often put patients on Equitest, and my main, not my sole purpose, but my main reason is to try and invoke the symptoms. As I said before, if it is the same kind of feeling, then that is very, very helpful. As you're aware, there are a number of patients who have very, very hard to define complaints, which are sometimes called visual vestibular mismatch or space motion discomfort or visually induced dizziness, as the proper term is now, which has been brought on by the Bharani Society. All these patients have complaints which are difficult to verbalize and sometimes not measurable. But if it adds up, if you are able to reproduce the symptoms on posturography, that is extremely helpful. As I said, patient is assessed by two of us. It's very important to have the assessments done on on the same day, not on 2 different days. And we always strive to do this. If a patient has fluctuating symptoms, quite often patients do, and I assess them on a good day, quotes unquote, and they get seen clinically on a bad day, then the assessments between the 2 clinicians quite often don't add up. Maybe some suspicions are raised, inappropriate suspicions, because the patient's problem is fluctuating. So it's very, very important. We assess the patients on the same day. It's very handy for them because, as I said, they have come hundreds of kilometers and they need to be assessed. But in our experience, and probably in quite a few of your experiences as well, a lot of these medical legal patients are telling the same kind of story. They give the same histories as non-medical legal patients. And we have tried this before as well. We try and take histories and guess whether they're medical legals or not. You can't do that. So it's extremely important to incorporate the quantitative assessment and the qualitative assessment. So to wrap up, we feel that we have arrived at a fair and comprehensive way of assessing the medical legal patient. One thing that must be remembered to say, well, can you catch all medical legals? Can you catch all people? Well, no, you cannot catch all people. The perfect embellisher, the perfect aphysiological performer will always get away with their endeavors. But it's very important, and I'm not going to take credit for this at all. This is a statement which was told us by Joel Goebel one time when we were talking. The perfect faker will always get away with it. But to have a system that allows for that is much better than having a system which runs the risk of hanging an innocent man. So thank you very much for listening. That's the way we do it, and I'd be interested in having anybody's thoughts or ideas. This booklet that we use is available online. There's the web address, and I'd be more than happy to talk to anybody via email. Thanks once again.
Dr. Mallinson, thank you very much for that really thorough and very interesting presentation. We really appreciate the time that you took in presenting and preparing for us today. Thank you so much. This will conclude the recording of today's presentation.